Hi, I'm John Stevens,
This is Matt Russell.
and this is Pod Have Mercy. Well, hey, Marc Boom, President, CEO of Houston Methodist. Thanks for joining us. It's been a while. A lot has happened.
It has.
But let's start. Why don't we just start? You just tell us how you're doing, you and your family. How are you?
I'm doing well, thank you. Juggling the usual two careers, three kids. Two of whom are living at home right now. One of whom really shouldn't be, but is kind of still the way school is, which is medical school and now School of Public Health for her. It's mostly virtual, and so it's better for her to be with us than alone in an apartment someplace. So that's been nice.
That's good. I was talking with someone, before we get into all the fun COVID stuff, I was talking with someone who's on the board at Houston Methodist, and they were telling me a little bit about, I thought this might be something right in your wheelhouse. I didn't put it on the questions I sent you, but he was telling me about this population health initiative thing that's going on that Houston Methodist is a part of, that's in some kind of a test or a study. Is that something you can kind of give some clarity? It sounded like a really cool partnership, or is that top secret and we're not supposed to talk about it?
Yeah, if I tell you, no, it's. I think there's a couple of things that could be referencing, but I think he's talking about Houston Methodist Continuing Care. This is a Medicare Share Savings project that we do. So the short version of it is basically a system where Medicare assigns through their primary care physicians, probably about 40,000 Medicare enrollees in the city. And we actually work with Medicare to try and improve the quality of care for those individuals, but also to be cost effective at a population level, as opposed to, I need a knee, replace a knee. This is more thinking about longitudinally, how do we keep people healthy and well and out of the hospitals? So, lots of work around chronic disease management, working at home whenever possible, appropriate care settings before and after. So it ends up being of real benefit to everybody, to the Medicare enrollee, who frankly, the way they structure it probably isn't even aware they're in this program, and to Medicare and to Houston Methodist as well. So it works out, and our doctors, it works out fairly well. I think that's what he was.
No, I think that's right, because it had to do with it. Well, the reason I said population health had to do with the health of the overall population and trying to do a better job of. In the talking about COVID, a lot of people that are affected by it really badly are people with comorbidities or just poor population health. And so it sounded like there was some kind of a thing that's targeting a broader spectrum of just treating, like I have an issue, I come and I get treated, but a much broader health initiative to try to.
Yeah, if you look at healthcare in historically, it's very episodic, right? So. You get sick, you come to the hospital, you get sick, you go to the doctor. And we're really trying to structure things much more to move towards a lot more preventive wellness care and longitudinal lifelong care. And it just so happens it's a lot better quality when you can do that. And the goal becomes keep people away from the hospital as best as you can. The goal becomes, keeping, for example, somebody with brittle heart failure who might get admitted 12 times a year. If you don't put a lot of structure and programs around them with something like this, you can actually put a structure around that. Maybe you can keep them out of the hospital 9 out of 12 times. Well, that's one heck of a lot better for the patient. It's one heck of a lot better care for them and ultimately outcomes for them. But it ultimately is, of course, much more affordable, et cetera, et cetera. And, the reality is a lot of that takes very intensive partnership between, the health program, whomever the payer is, in this case, Medicare, and the individuals, to really put a lot of monitoring in place, a lot of home care in place, a lot of the futures, wearables and other things like that. I mean, the heart failure example, a lot of people will decompensate because, they may go off their diet and they're a very brittle heart failure patient, and a nurse visiting them, or a early intervention when we see that when they get on their scale in the morning, which is connected to the doctor's office, that they're up 1.5 pounds and probably gaining fluids rapidly, that you can quickly have a nurse call. So you end up having structures in place where you're watching a population like that, and where physicians, nurses, teams are looking at how to keep those people healthy, and it's a pretty exciting thing. So we've done a lot of great work with that with our Houston Methodist coordinated care, and you'll see much more of this happen. Our market in Houston, there's not nearly as much of that happening from a private payer, from a United Healthcare, Blue Cross kind of realm as many markets, but you're going to see a lot of move that direction in the next few years.
The only thing I could think of is a scale that you weigh yourself that immediately talks to someone else. I'm thinking that's going to be a tough sell right there. I'm going to get in it. It's going to go, shame.
Shame. Just because you like to shout out on the weekends, not such a good thing. But in heart failure, for example, if you gain weight rapidly, you're not gaining weight because you ate a couple big meals. You're gaining weight because you're gaining fluid, right? That's the whole fluid retention issue, as an example in heart failure. But there's a whole lot of very exciting things we're focused on with our Center for Innovation, that you can imagine, right? And we right now do a virtual ICU where a lot of the monitoring of our patients, kind of supplemental monitoring, it's not replacing what's there, it's enhancing what's there, is done remotely across our system by somebody who has, all of the data and who can literally spot a patient who's going downhill much more quickly than a nurse who might be popping in and out of the room periodically does, because they've got all the, there's algorithms, there's, they're sitting in front of monitors with all these different things, and they can literally video wise be in that room assisting a nurse, so the nurse can hit a button on the wall, they're there assessing. It's really exciting, and you're going to see things like that happen in the inpatient setting. The difference between an ICU right now, you're hooked up to every monitor and every kind of wire known to humankind, right? I mean, on the regular floor, if you're recovering from surgery or something, you might have a monitor, that's got, a heart rhythm monitor or something, but we're not far from very inexpensive wearables that are going to ongoing do your EKG, or, obviously temperature, blood pressure, a number of other things like that. And so the next extension of that is, how would you monitor an elder patient who's fragile, who, might end up frequently in the hospital in their last few years of life, and keep them out of the hospital and happy and healthy with their family. And a lot of that's going to come down to how are we engaging with them in the home, thinking on a different basis than reactively when people come to us. But a lot of that's going to require a lot of neat technology. And so we're very actively working on many of this.
Yeah, the technology is going to be an important part of that. I remember when I first started in ministry, it was still, when I go visit somebody in a hospital, they still had like their chart was at the foot of the bed in the little holder.
On a clipboard.
So you could just like pick it up and like scroll through.
There was a lot of that in my early days. Oh yeah.
Yeah, there was no HIPAA, and there was no you could just scroll through. Oh, let's see what the doctor said about you. We don't do that anymore.
I remember working at the VA as a medical student, and the first job of the medical student was to, basically find every nook and cranny where some other doctor might have hid the films that you needed to review that morning, because it's all on, on celluloid film that you're going and running around, and of course paper charts and everything else. All of that has changed. I mean, there's a lot of wonderful advances of technology, a lot of challenges around technology, but where we are today is tremendously different. When we talk about a pandemic, I can't imagine having gone through this pandemic 20 years ago with the technology we had then, or 30 years ago when I was in med school. It would have been a very different experience than we ended up having this time. Well,
speaking of the pandemic, it's been a while since we visited with you, and I think we've gone through Delta and Omicron, and good news is it looks like things are trending down as it relates to that. But why don't you just give us an update of kind of how you see the big picture on this pandemic, and are we now in endemic? Are we entering that, or what does that even mean? I have no idea.
Sure. We're in Houston, we've had 5 major surges. The first turned out to be the baby, which was, that first when none of us knew or understood anything, and this thing was coming at us, and we're seeing all the horrible images out of New York and Italy. That ended up being, for Houston, not that big a surge, but we've subsequently had 4 very, very large surges. And interestingly, and this will be a question, for us later, is we've seen two of them happen in the summer when we're indoors, cold, our cold weather, which is air conditioning, and it's been interesting to see that. And so we led kind of the country in the South this summer with Delta, and then really Delta came through in the fall. And by the time we were starting to talk about Omicron, things were pretty good here in Houston, while things weren't so good in the upper Midwest and some other places from a Delta standpoint. So it hammers home that message that while the world may have a pandemic overall, it's really a summation of lots of local epidemics, right? That may be different times in different places. Omicron, we first heard about it, right around Thanksgiving weekend, right? Most people, I think, were waking up the day after Thanksgiving going, oh crap, here I had this nice holiday, and now the next day they're telling me something's coming. And we were a few days before that, obviously, in healthcare, but not long before, because it went so fast. And obviously we saw how rapidly something can spread worldwide if it's infectious enough. And things shot up. And fortunately, we're on the backside of that. We're big time on the side of that, which is, really, really good news. From an infections perspective, it sort of rewrote the rules. Unfortunately, it was a variant that is highly, highly infectious. Probably the only, virus we really know of that's more infectious than Omicron is measles. And it's not probably quite at measles levels, but it's approaching it. But you're talking probably 5 to 6 times as infectious as the original China variant that came out. I mean, the one that was in China and in Wuhan originally. And then, of course, we had a series. I mean, really what hit the U.S. ended up already being a mutated strain. And then what we saw that summer was another mutated strain. And then, of course, Alpha and Delta and now Omicron. As you came through that. And each time it's picked up different characteristics. So Delta was already probably triple as infectious as that original one that emerged in Wuhan. And then now this, which is far more infectious than that. Now, thankfully, and I mean, I can't overemphasize the thankfully, it turned out to be milder, because if it was as severe as what we originally saw and that infectious, I mean, it would have been an absolute mess. And so we saw, record numbers of positive tests, record numbers of people getting sick, but a much lower proportion getting sick enough to need the hospitals. So it's amazing the way it's worked out this way. But, the last 3 surges, last 4, the summer of 2020, last winter, summer of 2021, and now this one, plus or minus 15, 20%, they've all sort of peaked in around the same realm from a people in hospital standpoint. Once in hospital, we didn't see dramatic differences in outcomes versus previous ones, but far fewer people were getting admitted. To put that in perspective, we collectively, it's the city does this with Rice and Baylor. They look at wastewater, for how much virus is in the wastewater. What are you pooping and peeing out in terms of virus?
I don't want that job.
I was going to say
2 reasons. It's really great imagery there, I know, but
Thanks,
really 2 reasons those numbers go up or down. It's the number of people who are infected or the amount of virus somebody is shedding, right? So with Omicron, way more people got infected really quickly, but you also probably had really high viral loads. So if I took, person A and infected them with Delta, they had, X virus getting shed. And if I gave them Omicron, they had 2 or 3 or 4X virus being shed. So there was a combination of that. And what the city did was say, okay, on July 6th, 2020, so this was that, the second surge, but the first really, really big one, and that was the peak day of that really, really big one. They said, this will be our benchmark day. How much virus do we find in the wastewater? And they call that 100%. And in Delta, we got, to 300-400%, something like that. And by end of November, we were like 75%. So we had less virus in the water than during that peak at that point in time. Well, the 27th of December, it peaked at about 1,800%. So in other words, there was 18 times as much virus collectively in the wastewater as there had been during that other surge. So just massive amounts. And it correlated directly with what we saw at the hospital. That day after the Christmas weekend, we diagnosed, our peak day ever had been 550 tests. We did about 1,200 positive tests that day.
Wow.
So had we had what we used to have, which was 40% of people getting admitted, we would have admitted 450, 500 patients to the hospital that day. Now, remember, our peak census was 850 to 900, and people stay for average of, let's say, 6 days. So that would have been like having 2,500, 3,000 people in the hospital if you kind of had that for a few days in a row. And thankfully, because it was milder, fewer people got admitted. What we saw after that was that probably the younger, kind of more mobile crowd got infected first. And then as the infections were coming down, the hospitalization numbers were not coming down. In fact, they were even coming up. And it was because we saw older, more vulnerable people getting infected. The people who were a little more careful, this was everywhere. I mean, I'm sure you experienced it in that couple of weeks. It was everywhere. But the good news with Omicron that we saw in South Africa, we saw in the UK, and that we've seen really worldwide, and we're seeing US-wide, is from an infection standpoint, it has a very sharp peak and came back down very quickly. The hospitalizations are lagging, but nonetheless, they're down very significantly. And so that wastewater, which peaked at 1,800%, was 167%. It's always a week in arrears. So, that was reported yesterday for the previous Monday. And so, while it's not back down to zero would be normal, but it's not back down to kind of pre-Omicron levels, it's starting to approach that. And so I think we're going to see the next 3-4 weeks, things continue to get a lot better. And you'll see the hospitalizations are following. And by March, I think we're going to be in really good shape. And we're kind of going to be in that sort of, one of my key messages would be we're going to be in the sort of seize the moment timing. I don't know where things are going to go. I don't know if there'll be another surge, but we need to be, seizing the moment when we can. And we need to be pivoting when we see warning signs like the day after Thanksgiving, realizing Omicron's 2 weeks away, and changing behaviors and changing protection then, and kind of pivoting back and forth if we have to. So that's a long-winded answer to your question, but that's kind of where things are today.
Yeah, one of the things that's interesting, and one of the things I sense, like a big thing, and I've gotten this from a lot of people, they want to know about natural immunity. They want to know how many times can you get COVID. There are a lot of people I run into who say, well, I've had COVID, I won't get it again. But then I've met someone who's had it 3 times. So, when we talked, I think it's been at least a year, maybe more, about natural immunity. At that time, you made the statement that, you can do a lot of scientific, like case studies, testing, or whatever you call it, on vaccination, but you can't really do the same kind of research or studies on natural immunity. But is that happening more now, or do we, what does natural immunity mean? How does it work?
Now, the good news is a couple of comments. There's a whole lot of data out there now, which is good news. I'd say for the better part of a year, and I think that rule of thumb still largely holds true. What we've often said in town halls that we do, and our chief scientific officer, our chief academic officer often has said is, kind of a lot of the data supports the fact, no question, let's go to vaccines first, that, clearly 1 dose is not enough. We knew that from the beginning. 2 doses are necessary. I think with the benefit of, perfect hindsight, probably those doses would have preferably been spaced out a little wider. But that really, it's probably the 3rd shot that is sealing the deal, so to speak. Whether that permanently seals the deal, that's not what I'm saying. But it certainly gets people to really significant levels. And I'll come back to some data on that in a second. And what he and I would talk about often on our town halls is that, think of each of those times you get a shot, that's your body seeing the antigen. An antigen is something that shouldn't be there that your body reacts to and makes antibodies. When you get COVID, that's exactly what happens, right? So if you get COVID, your body's now seeing a foreign substance, an antigen, and is making antibodies. So roughly, we would look at the data, and rough rule of thumb, getting COVID was sort of like getting a shot on a rough rule of thumb. So was it as durable? Probably not. If you looked at people who had 2 shots and then COVID, were they more protected most likely than somebody who just had the 2 shots? Absolutely yes. And so we still think that's a pretty good rough rule of thumb. Now, Omicron, as I said, sort of rewrote some of the rules. we clearly saw that if you go back a year and you were looking at the Alpha variant, and keep in mind that the vaccinations were formulated against the genetic sequence from the originally isolated virus that was in Wuhan. So already what mainly hit Italy and the US and then the rest of the world was already another variant. And then what really hit us in the summer was another variant. And then you're talking about Alpha by the time we were dealing with the winter. Fortunately, those vaccines still work, even as all of that's changed, and then later Delta and Omicron. But Omicron showed itself able to evade immunity very significantly. We think there's a couple reasons for that. Well, one of which is clearly people's antibody levels wane over time. They go down over time. Whether you're, naturally acquired infection and you had COVID, or whether you were vaccinated, we know those go down. If I give you a vaccine or an infection to anything, and it'll just depend on what disease it is, but antibodies always go down because you'll mount a response, and then there's sort of, there's an acute kind of antibody that comes up, and then there's a little longer term antibody that comes up, and then two other things happen. You have at least two, but to simplify, you have some B cells, those are what make antibodies. You have some memory B cells, so they remember, aha, I've seen this. And so if they see it again, they're like little factories, and they'll pump out a bunch of antibodies. But those antibodies are not there every moment of every day, and I'll come back to that in a second. And then there's T cells, which are really your long-term, what we call cellular immunity, which are part of the whole immunity as well. We know both of those are there, and for most things stick around for a long period of time. But now with an Omicron, which is highly infectious, it's in huge quantities when you're near somebody with it, and it has a particular propensity to bind very strongly to upper respiratory tissue, much, much more strongly than the other variants did. The good news is it probably has a lower propensity to bind to your lungs, which is what makes you really sick, right? It's the people who get pneumonia generally who then really, really get sick, which is probably part of why it's been milder. Well, to prevent that huge bolus of infection, you need a lot of circulating antibodies, and you probably also need some antibodies on your surface membranes in your upper respiratory tract, which are generally only there in the early days after being sick, or in the early days, when I say early days, first couple of months after being vaccinated. So it's not a huge surprise. And what ultimately though was disappointing is, whereas the vaccines were highly effective at preventing almost all infections originally a year ago, now we were waking up saying, okay, they're not preventing infections. I mean, they prevent a lot of infections, but they don't uniformly do so. But what we saw, even with two-dosed people, so people who just had the routine, the fully vaccinated series, markedly diminished risk of death, even if they got infected, markedly diminished risk of being in the hospital, which is, of course, at the end of the day, what we care most about. And then what we saw was when you give people a booster, you can bump up the antibody levels. So for some period of time, you're less likely to get infected. Whether that'll continue or not, we don't fully know, but I'm going to guess no. But you can really boost those levels of protection against what really matters, which is hospitalization and death. So right now, the most recent data says if you take an unvaccinated individual and you compare them to an individual who's had 2 doses of a mRNA vaccine, you're probably about 20 times as likely to die. If you take a boosted individual versus that unvaccinated individual, there are numbers anywhere from 58 I've seen recently to as high as 90. So probably a 4 to 5 times less likely to die even than the people who are double vaccinated. So that's why we urge boosters so much. We don't fully understand every iteration of I had COVID first and then I got a couple of shots, or I got 1 shot, then I got COVID and then I got a second shot, or, et cetera, right? There's a million permutations of that. When you think of it on a population basis, and this is how we think of it from a hospital standpoint and from our employee standpoint, at a population level, we want to drive this away. And so at a population level, whether you've had COVID, whether you haven't had COVID, wherever you are in all those permutations, given that the booster shots and the original vaccines are so amazingly safe, we don't see a downside to taking it for the vast majority of people, even, no matter what that scenario is. So we require boosters now across our hospital system to keep our employees safe, but most importantly, to keep our patients safe. So hopefully that gives you a little bit of information. Again, my rough rule of thumb for people is, think of it as a dose, and your goal is to get at least 3 doses if you want to be the highest level of protected. Personally, I have not had COVID, but had I had COVID, I'd still have 3 doses of vaccine in me, no question. And I do have 3 doses of vaccine in me. And I still recommend that to my own personal patients, in terms of getting that, because the only sort of controlled, measurable, we fully understand kind of what it does, or close to fully understand what it does, way of getting somebody antibodies is through a vaccine. And because they are so incredibly safe. The other, and that brings me to the other point, which is one of the challenges with the, quote unquote natural immunity, or having had a version of COVID and then making antibodies. If you have a mild illness, you tested positive but had minor sniffles, or you tested positive and didn't even know you were sick, we're not convinced you're mounting as big an antibody response by any stretch as if you were really sick with COVID. And so it's hard to understand, is there a standardized level? How do you do that, et cetera? And so, again, my recommendation is that people be fully vaccinated, and then when it's their time, get that booster, because it is protecting people.
And so I guess that's why it's hard to point to a study or anything on natural immunity, because you can't control the variables, I guess. I read somewhere about some study where they were actually giving people COVID. Huh. And I don't remember if that was in England or somewhere for young adults.
I think it was UK with one of the, I think it might be Oxford, but don't quote me on that. They actually did, younger, healthier volunteers with challenge studies, which, happens sometimes with infectious diseases. The other thread I'll hear sometimes is, well, I should just go get it, right? And I still don't recommend that. I mean, first off, get vaccinated. And second off, we just don't fully understand all the ramifications of having COVID. We see long COVID. You don't want long COVID. It's no fun. And we see much less long COVID in people who've been vaccinated than people, even if they get COVID, then, obviously, than people who, have never been vaccinated and get COVID and sometimes have that. And you don't want to have that. So.
My mom sent me to my friends down the street when I was little to get chicken pox. We had a chicken pox party.
That was done commonly.
We didn't really know what in the hell we were doing. She didn't know what the hell she was doing, but that's how I got chicken pox.
Really?
Oh yeah, it was like a big thing.
There's plenty of parents who have 4 kids, and in the old days they'd have one kid with chicken pox, and they made sure the other 3 got it because they didn't want to deal with it 4 more times. But and it made the pediatrician shudder, because the pediatricians see the rare child who gets a bad, varicella pneumonia, chickenpox pneumonia, and gets incredibly ill, right? So even that. Nowadays, of course, we give chickenpox as part of the vaccination series, so we can avoid that. But most certainly, I don't ever think that's a great idea with any infectious disease. It's a little bit of playing roulette, with the outcomes. I mean, obviously, overwhelmingly, people will be fine and have a mild illness, but there's going to be the exception, and nobody wants to be.
Well, I'm from South Georgia. We just slap some mud on it, and you run back outside and you play. I mean, that's how you didn't clean up the wound. You just kept going. Hey, listen, shifting gears, you've said a lot, and I think you've done a wonderful job, and I know there's going to be people that disagree with me on this. Some people don't like me, how I've handled things in the last 2 years, and I'm sure you've got some that love you and think you've done great, and others that don't think that. That's welcome to the club. But when I think about how well you've done to try to stay as apolitical as possible and really focusing on healthcare as a leader in the hospital, I think it's been really remarkable. Do you think, or do you feel or sense that are we in a good place with coordinating between government and healthcare? It just seems like that's been a rocky road for how the interplay goes on.
Yeah, that's a great question. So we had a number of guiding principles throughout this, and we've done our very best to adhere to them. One of those is, stay apolitical and data driven. Now, let me be clear, once the political realm evolved to the point where, you could sometimes tell what party somebody was with by whether they chose to wear a mask or what, those kinds of things. by definition, when we would follow the data, somebody would think we were being political. So, not everybody would agree we weren't, but I can tell you, we've followed the science every step of the way. And as a healthcare institution, our sacred obligation is to keep people safe and keep the community safe. And so we've done that every step of the way. And so I'm proud of what we've done with that. My philosophy from a elected official standpoint, if you want to get into kind of the politics side of things that you're asking, we would work with any elected official anywhere if we could help them help the community, or if they could help us help the community. And so, I get countless people from both sides of the aisle, and the whole spectrum on either end of the aisle, did we work with. And of course, for the first year, I worked with a lot of people who were, red from the federal level. And the next year, I've worked with a lot of people who are blue from the federal level, just because that's where obviously the federal government was. Locally, I worked with the county judge, I worked with the mayor and many other people. And then, of course, at the statewide level, worked with the governor, and, agreed with all of those people a lot of the time and disagreed with all of those people at other times, at times, quite frankly, would have one conversation with one yelling at me for one end of the spectrum, and another conversation with one of them yelling at me for this exact opposite end of the spectrum, literally in the course of 3 hours. So unfortunately, things did get and are still very political. I think one of the things we have struggled with as a country is that our public health infrastructure was woefully inadequate at every level. So, CDC to city to county to state, et cetera. And let me be clear, I'm not throwing stones at a lot of good people that I've worked with. What I'm saying is we didn't have the infrastructure at any one of those levels, the investments at any one of those levels, the tools, the surveillance activities, et cetera, et cetera. And so, when I talk to other hospital systems around the country, we all feel this way. We've stepped in and done a lot of that work with them and for them as partners. I mean, I have the utmost of respect for all of those individuals. It's just they were under-resourced. And when you start thinking about what the collective institutions of the Texas Medical Center could bring to bear, when you have under-resourced of any one of those levels of government, it was pretty significant. So the good news is I think we've partnered very well, and you've seen a lot of collaboration there. And at the end of the day, every one of those people ultimately wants the same thing, right? Nobody wants people to suffer. Nobody wants people to die. Nobody wants the economy to go south. Nobody wants our kids not to get educated. There's just obviously dramatic differences in opinion on how things would be approached, and unfortunately got very politicized. One of the things I've talked about all along for us was what we saw as I called it the sacred and, our sacred responsibility. And the and is we have to care for patients with COVID, patients without COVID, and protect our physicians and nurses and other personnel. And I would turn that back around and say the political and is that you need to protect people, manage COVID and kind of minimize the death and suffering from COVID, but you got to protect the economy and you got to educate our children. And unfortunately, what we've seen is sort of the irresistible urge in the political environment to not go to and, but to go to or, right? Once, if you're in politics and you carve out your spot, it's real clear where you are, who you are, and then you can, start lobbing bombs at the other side. And, that's the antithesis of what we need during a crisis. It's the antithesis of what we need during a pandemic. What we need is, bipartisanship. We need, people, working together, ironing out differences, and then coming to consensus. And that's been, frankly, one of the biggest areas of challenge that we've definitely had to face.
Yeah, there was a study, not a recent study, of who do people trust on this thing. And what I find fascinating, and it really says a lot about Houston Methodist, it's like your local, like employers were real big. They trust their employer, which is interesting. But your local health care, not the CDC. No. The CDC actually was, because I think it's tied in, the CDC got tied into the politics. But local health care, the local hospitals, your employer, way higher than the president or other things like that, depending on which president it was. So I think that means, nowadays people are listening to you. They're listening to the TMC, and I think that's a big responsibility for you all to know that people are listening and they're looking to you. for guidance on this, and they pay attention. It may not feel like that because sometimes we only hear from the ones that don't like us, but a lot of people are.
And I think one of the biggest take homes from that was, from all those studies, there's been a couple like that, is that trust in the employer, right? It's the environment you go to, you work day in, day out, which is, I think, a heartwarming thing, right? I mean, that people tend to like where they work, and they trust the people they work with, and they trust the people and the institutions they work for. So for a long time, we've been saying, ultimately, employers have to be a big part of the solution, right? If we have to figure out how to, hit the sacred and of, let's control COVID and minimize suffering and death. Let's control and optimize our economy, and let's get our kids educated. At least the first two, if not all three, really, are very majorly the responsibilities of employers. And so where employers had a multitude of tools to encourage, careful behavior, to encourage vaccinations, which work, et cetera, we've encouraged them to do that in any realm of different ways, from educational programs, town halls, to encouragement, to incentives, to disincentives, et cetera, et cetera. And many employers, in fact, I would say most employers, have stepped up and done that. And that's, a very good thing for us.
That's great. Matt, you just got to jump in. I got these questions just going through. So the big thing now is, you can just push me out of the way.
No, go for it.
Big thing now, conversation. It's like anything. The vaccines became controversial and political, but now they're getting ready to, or they've approved, at least for emergency use, children under 5. People have concerns about vaccinations in children. They talk about, and a lot of it, infertility, myocarditis, all these sorts of things. But as it relates to what you've seen with the children in vaccines, speak to that a little bit, the studies and stuff that's been out there.
What we've seen with the COVID vaccines is, pretty standard for any new medication, drug, vaccine, et cetera, is, some are obviously developed specifically for kids, for an issue that only happens in kids, but most things start in the adult world and then move into the pediatric world over time. So what you've seen is a very standard approach, which is, they started with a large population, 16 and up or 18 and up, and then have marched down into other populations. That is smart medicine. It's smart science, right? Because, we want to see if something works, look at the safety, look at the effectiveness, and starting with adults makes sense for a whole multitude of reasons. In the case of COVID, that's where the most death was occurring. Obviously, you're talking, 200-pound people, not, 10-pound people, and so there's a bigger and broader safety window as you look at things. And so this is very standard. And so what we first saw was the 12 to 16s, and then we saw the 5 to 11s. And now, as you're alluding to, you're seeing, a bunch of the under 5. So step back and ask about, because all of this is ultimately going to be a risk-benefit ratio, right? At the individual level and then the societal level as well. When you look at kids, and I'm going to use that broadly, 18 and under, who gets really, really sick from COVID? Well, first off, far fewer than a bunch of 80-year-olds, right? We know that, thankfully, unlike the Spanish flu, where, it was 18, 19, 20-year-olds who were getting most devastated, 100 years ago. Obviously, we'd be having very different conversations had COVID reflected itself like that. So when you look at that age, when you look at kids, it's kind of a bimodal peak. So the kids who have died tend to be teens, and you'll see risk factors for that. Obesity is probably the strongest risk factor outside of obviously a kid who's being treated for cancer or has some immunocompromised. But you'll see kind of that 15, 16, 17, 18-year-olds, a fair size peak, nothing like 80-year-olds, but compared to the 5 to 11-year-olds, much lower. And then you'll see a bunch of 1-year-olds and 2-year-olds. You'll see the youngest end. So you have that kind of bimodal peak. The other thing you see that's really bad in kids is you see the MIS-C, which is the multi-inflammatory system, disease that they have, which if your kid gets that, thanks to places like Texas Children's and other great pediatric hospitals, they'll probably pull them through. but it's going to be weeks and weeks of severe illness, intubated, dialysis, your gut failing. I mean, all sorts of things. And mainly because honestly, if you gave that illness to an 80-year-old, they die, but kids are resilient and they pull them through. But that's life changing and devastating for families. Well, a lot of that's in that kind of 5 to 11-year-old age group. So there's another reason in that group. But the other key reason is that, remember, very few people have only children, right? But there's a lot of 8-year-olds who have 1-year-old brothers and sisters, or, et cetera, et cetera. And so from an individual perspective, you can look at that kind of, benefit profile, but you also have to think about family health and then school health and population health. What's happened is these vaccines have proven to be amazingly safe as you look at kids. In the mRNA vaccines, which is really what we're using now, the two, Moderna and Pfizer, we've seen, and you alluded to this, some myocarditis. Myocarditis is an inflammation of the heart, of the muscle of the heart. A lot of people who get COVID get that, and far more people with COVID get that than with COVID vaccine, but I'll come back to that. But a lot of other viruses that run out there may give people of any age, that there's a list that long that causes that. Fortunately, it's been incredibly mild. And it's mainly occurred in sort of late teens and 20s young men, much greater male than female. And we've not seen nearly as much in younger children. We've also seen it probably highest on the second dose and much lower on the third dose in all of the studies that are out there. But the incidence of it is far, far less than the incidence would be if your child gets COVID. And so, at the end of the day, the American Academy of Pediatrics strongly urged and strongly recommended COVID vaccination. And each time you've marched down that age band, they're strongly urging that parents do so and get their kids vaccinated. And you'll see the same thing from them on the under 5 age group as you look at that. My youngest is 16. She was 15 at the time vaccines came out, so she wasn't eligible for quite a while. So we enrolled her in a trial, and she actually got Moderna in March of 2021, and did both. And it turned out she was in a double-blind trial, but she got the actual vaccine, and later we got her a Pfizer booster after she was 16 and qualified for that. So she's been triple vaccinated. I can tell you, and my wife's a pediatrician, I think if I had a 2-year-old, 3-year-old, and they were releasing the vaccine, I'd be first in line. We'd be getting them vaccinated. I can tell you, obviously, if I had a 7-year-old or whatever, we'd have done that long ago. When we opened up that at Houston Methodist, in other words, the approval went and came out, the first people in line were all our doctors with their kids. Wow. So, they're voting with their feet and leading by example of the right thing to do. So we would urge people to go ahead and get those kids vaccinated. And keep in mind, it's amazingly safe for the kids. They don't live in a vacuum. They live with their brother, their sister, who might be higher risk. They live with mom and dad. They visit with grandpa and grandma, et cetera, et cetera, et cetera. And so, keep that in mind. The other thing I'll say is a series of pretty remarkable studies out there. You can look at families of 2, 3, 4, 5, 6, and every time an additional person in the family gets vaccinated, it protects. The probability of somebody in the whole family getting sick goes down dramatically. So when mom and dad got vaccinated, but the kids couldn't get vaccinated yet, those kids were already getting protected more than a kid whose mom and dad didn't get vaccinated. When mom and dad and the 17-year-old got vaccinated, or 15-year-old, let's use that example, and there was a 8, 6, and 5-year-old at home, the study will show that those 8, 6, and 5 were actually already now incrementally protected. And so, we strongly recommend that whole families do go out and get themselves protected.
I want to be faithful to your time too, because you're always so good to come and be with us. And so I want to wrap this up by 3. But I had two more things really. One is, I think the one that gets me is like, what concerns you the most now as we move forward? Are we I think about the word endemic or pattern. You mentioned a little bit about seizing these little moments, but when you look at what looks ahead in your crystal ball, no one will hold you to this, but what do you see? What makes you really excited, but what also concerns you as you kind of look into the crystal ball in the future?
Yeah, and if COVID has taught us all one thing, it's humility. It's taught us all be careful with what you predict, and but I'll tell you, I think what we have, fair degree of certainty short term, a lot of uncertainty, obviously, over the longer term. There's a lot of chatter out there about, is Omicron it? And anybody who tells you Omicron is it is, by definition wrong or potentially wrong. And anybody who tells you Omicron isn't it is by definition wrong, or potentially wrong, because none of us truly know the answer to that. What we do know is a couple things. One is, we've seen this have patterns. One of those patterns, and I alluded to that before, has been in the warmer climates. It seems to have shown up in the summer when we're air conditioning. In the colder climates, it seems to be, showing up in the fall, and then everybody's getting hit in the winter when it's cold for everybody and we're indoors, right? We've seen much less in sort of the shoulder seasons for us when, we're all outdoors a ton because it's not so hot or it's not so cold. So is there a seasonality we can predict? Will we see another surge this summer? Maybe. Will we see winter surges? I would say probably. We'll see some sort of periodicity for some period of time, much as we see a cold or a flu. We're very hopeful that, what we see is that kind of periodicity, but without massive spikes. We do know that we have a lot of immunity out there now, right? I mean, 2/3 of the population in Texas has gotten vaccinated. Unfortunately, we can't seem to convince the other third to do so. And we've only got about 1/3 of the population's been boosted. And so we need to get those folks boosted. And, to be blunt, I'm kind of giving up trying to convince the people who haven't gotten vaccinated at all, although that's the best thing we could do. But I'm still working hard on the people who got vaccinated before and get boosted. But the biggest impact we could have societally is get the people unvaccinated vaccinated. But the reality is, at some point, if you've not gotten vaccinated, and now to some extent, if you have gotten vaccinated, lots of people have had COVID somewhere along the way, right? So there's a lot of immunity out there. How durable it is, how effective it is, still a lot of question marks. So I think we are, rapidly entering a very good period. I think we have the quite significant possibility of having this spring be far better than this fall was from a COVID risk standpoint. We had a window there, if you remember, kind of May into mid-June last year, where it was really good, really good.
Thought it was
and then,
over.
Of course, Delta came around. Everybody did. And then Delta hit. And Delta taught us that, hey, this thing's going to mutate. As long as we have, hundreds of millions, probably in the billions of people around the world that are susceptible, unvaccinated, you're going to see variants emerge. Now, so far, the variants have mostly emerged, the ones that have gained hold because they have a strategic advantage, have been more infectious. And thankfully, they've been at worst kind of even, and now with Omicron probably better from a individual risk standpoint. Again, thank goodness, or it'd be really different. There's no guarantee that is the case if there's another variant. The strategic advantage could be a variant that's actually less infectious, but it completely avoids every sort of antibody that's out there, whether you got it from having COVID or whether you got it from a vaccine. So I think we can't predict that right now. I think we need to assume that for a significant foreseeable future, we're going to be living with COVID. How big the surges are, how frequent the surges are, I have no idea. I don't think anybody truly knows. Kind of my fundamental message with that is, let's seize the moment while it's good. That doesn't mean throw all caution to the wind and don't use any common sense. Use some common sense with that, especially if it's there. I mean, if we're down to no COVID for a while, okay, fine, but we've never gotten to that. But we need to figure out how to pivot more quickly when it does come back, right? Omicron, we knew. I mean, in fact, obviously it was Thanksgiving weekend. We saw our first, and we sequence every single genome. We've done 70 something thousand. We saw our first case less than a week later in Houston. And, 2 weeks after that, it was 95% of the cases here. There was a moment in time there where we could have all said, okay, we're going to have to start acting a little differently. And we could have attenuated this rise and obviously saved some lives and preserved hospital capacity and some other things like that. So, that would be one, key message. The other thing that I'm very hopeful and prayerful for is we have a couple of really good treatments out there, especially a drug called Paxlovid, which is, in trials basically cuts hospitalizations by 90% and thereby, death by at least 90%. That's a game changer if you can get that to everybody who gets a severe infection. Right. And it works totally differently than any antibodies that, whether they're derived from vaccines or derived from infection. And there's every reason to believe that at least for the foreseeable future, any variants would still be susceptible to that. It's not to say at some point, like with antibiotic resistance, you couldn't have something that develops some ability, but it kind of works in some of the replication machinery in the cell, for the virus to replicate itself. And so it's a really good drug. The problem is you can't get it. Now you can start to get it as the volume of people is coming down. If we can get that pushed out, I've said a couple of times, been quoted saying we kind of needed the Operation Warp Speed for the antivirals, because we need it so readily available that if we see, the whatever you call it, the next variant, and it's blowing up, that we have tons available and every physician can prescribe right away when people get sick. It could change the game.
So the difference is unlike a vaccine, this is like I get a flu vaccine, but if I got diagnosed, they'd give you what's the antivirus they give you for flu?
It's like Tamiflu.
Tamiflu, So this is like the pill version antiviral drug.
Exactly.
That would be great.
Exactly. Wow. Exactly. And so it's there. It exists. It's being prescribed. There's another one as well, but as long as this, if that was the only drug, we'd be saying, okay, pretty good. This is just far more effective, and I think the other one has some reasons we don't love its safety profile. If it's the only thing left, in certain situations you'd use it, but it's not the first drug we'd reach for. This one's a great drug. Its downside is that it does have some drug, as a physician, we're always thinking about drug-drug interactions, right? If I put you on a new drug, it's got a long list of potential drug-drug interactions. So some of the sickest people who may need it the most are on 18 drugs, and sure enough, when you run their drug list, you find one or two that you're like, you can't use these together. So which is a significant downside. But for many, many people, it's going to be the Tamiflu that you reference, in the future. And so I'm cautiously optimistic with all of that. But look, if anybody tells you they know for sure where things are going, they can't. There's just no way to know that. I am hopeful and prayerful that, it's going to be hard to outcompete an Omicron that is almost as infectious as the most infectious virus we really know, which is measles. But we don't know that for sure. And so, we'll just have to see. As we saw, there's a sort of sister to Omicron, Omicron's BA1, this is BA2. You've probably seen some press about that it's a little bit in South Africa. Denmark's been hit very hard with that. UK's got seems to have, a 10 or 15% edge over Omicron. So we may still see that. It doesn't look like it would cause a big new surge. It probably would just slow down the decline that we've got, is what most people think. But it does show that this thing's constantly mutating, and it can always find something new. So we need to keep getting the world vaccinated. Obviously, when it runs through and a lot of people got Omicron, they're probably less likely to get infected and harbor a virus over time. We don't know exactly where. Omicron was a huge mutation. Like I think it was 35 base pairs basically on there that got changed, at least something like that. And that's not an easy thing to happen. So probably the leading hypothesis for that, and probably why it was in South Africa, or could have been in anywhere in sub-Saharan Africa, which is HIV, and a lot of people who are chronically immunocompromised. So if you're chronically immunocompromised, you may not clear the virus. In other words, you get it. Maybe it's held at bay, but it sort of lives in your body for months, and instead of clearing it like people who aren't immunocompromised. And that just gives it lots of chance to mutate and accumulate mutations, and then eventually, a mutation happens that's a strategic advantage for it, and it infects somebody else and blows out. That's probably what happened with Omicron. We don't know that for sure. There's some other hypotheses around that. Could it have been what's called a reverse zoonosis, where it goes from man or human into animal and animal back to human? That's possible. But the leading hypothesis is probably immunocompromised. So
it's good that you bring up other countries. We tend in America to like think about this COVID thing just about us because, you know, it's always about me. I mean, that's the world revolves around me and us. But I think, you know, we have some United Methodists here and United Methodists that'll listen to this. And
Globally.
We're supposed to have this international global general conference in August. They're going to make this decision in less than 2 weeks, I think. Yeah, but one of the limitations is not only are these delegates, many of them not vaccinated, getting a visa to travel into other countries has been a real big issue too. But I think about not only do you think you can have an international conference at that time, or who knows, but thinking about how we get the rest of the world either vaccinated or what needs to happen so that these, I mean, like when you look at Africa, it's very few people have been vaccinated, but it hasn't had a huge like breakout like when you saw Italy or Germany or some of these other countries yet. I don't really understand all that. The South Africa thing makes sense, but I was going to just kind of ask you, do you think we're going to have general conference? That was really the question.
Or should
Yeah,
we?
that's a complicated question. I mean, to the Africa one, there's a few possibilities. One is, remember, it is a very, very young population compared, if you look at especially sub-Saharan Africa versus the United States, Europe, Japan, and, you know, of course, severe infections mainly been in older people. So that may be some of what we're seeing. South Africa was about 35% vaccinated when it got hit with Omicron. I mean, if you look at South Africa, and if you maybe imputed that some of the surrounding countries, you're going to have a majority of people will have some immunity now. A lot of it, you know, from being infected, you know, and then you look at many other countries and, you know, there's been access, but not enough. I don't know the answer for you. You know, we have, you know, again, that kind of combination of seize the moment and coexist with this virus, right? I mean, have I traveled? Yes, I've traveled out of the country during COVID over the last 6-8 months. I'm careful. You know, I wouldn't go right at the middle of a peak. But there are ways to do that. But I'm triple vaccinated, right? So I know when I'm going there, I'm less likely to bring it with me, but I'm also less likely to be at risk of anything severe. You've got to think about people who have not been vaccinated, their risk, what they can bring with them, but more importantly, really their risk. And that's a complicated, obviously complicated issue.
I knew you weren't going to answer that question. I don't blame you. I wouldn't answer it either. I don't know what's going to happen. I don't know what's going to happen most any days about anything, but especially that. So,
yeah.
Hey, I always appreciate you coming on and catching us up. But hey, Stacy Alt sent us out. I know some of the churches, and we are officially adopting the emergency division. I think it's the emergency division down there to bring them goodies and snacks and cards and goodwill and wishes. We really appreciate all the work they do. And I think that's a great idea for local churches to adopt ERs and emergency division, especially the frontline workers. We want to just let them know how much we appreciate them.
I love that idea. It's been, you know, I mean, yet again, hard. This one was different in that it was hard. I don't know. The summer was really, really hard because we saw so much suffering and death in people who should have been vaccinated, could have been vaccinated. Yeah. It was that missed opportunity. As a healthcare provider who's sort of sworn to protect people, you know, it just was really difficult. Omicron was hard because it blew through everybody. And, you know, we basically had staffing shortages at the same time as we had, overwhelming numbers of people coming into the hospital with Omicron. So, and it's just that kind of really, again, kind of thing. And again, the second holiday season in a row for our people that they were, hitting peak times. And that's been a hard thing. So all those things you can do to pray for them, to boost their morale, to do nice things for them, richly appreciated. Because what happens post-COVID or post these surges is things tend to get really, really, really busy because, all the deferred care and other things that happen. And so they kind of don't get a real time to catch their breath. And so it is much appreciated.
Well, we appreciate you. Thanks for joining us.
Thank you, Mark.
Thanks for having me.
And have a great day.
You too.
They don't pay him enough money.
No.
I don't know what they pay him.
It's not enough.
Probably a lot. I think he gets paid a lot of money, but it's not
enough. Yeah, maybe they can give him a pay raise in terms of paid out in vacation, just not being around after this thing is over for a while.
Yeah, they just need to buy that dude a house in like Cabo.
Yeah.
Well, what did you learn? I'm sorry, I just kind of blew through there to get the questions in because
No, that's good. That's good.
Thanks for participating in the
sure,
podcast
man, I'm just
today.
here to
Glad you could come.
It's eye candy. Right. It's interesting, the natural immunity stuff, because that was one of the questions I have in terms of that kind of as we move towards whatever that herd immunity is. But just seeing that like the vaccination, triple boost, all those, if we could, that stuff still works. It's still the efficacy of it, it's still there. So
I feel like people are getting a little better about all of it. I mean, we kind of lost our minds for a season.
Yeah.
All over the map. I mean, no matter where you were on the spectrum.
Fear does that to you.
We just kind of lost our minds. But I see, it feels like, to me, it's starting to get better.
Yeah.
Maybe it's just because I'm spending time around good people, but
that helps.
I don't know. I mean, on all of it, the politics and the COVID and everything. And, I'm glad it's going down. We got a good season. Weather's nice. Go outside.
Yeah. I think people are also like, it's happening at a good place where people are both hungry to come and connect with other people, and there's a little more kind of confidence we have that, we can take care of ourselves, admit it, whatever that looks like for a person, but we don't have to isolate. We don't have to move, back from each other. So that's encouraging.
Anything we need to promote, push? Hey, make sure you rate the podcast. Rate it good, though. Don't rate it bad. Make sure you like it, and make sure you subscribe, whether it's on the YouTube channel, whether it's on the YouTube channel, or your favorite podcast app. Make sure you like, and make sure you subscribe. Make sure you share. Pod have mercy. I'm John Stevens.
And I'm Matt Russell.
And this is Pod have mercy.